So I'm really delighted that David Pearson is going to be addressing us. David is a former president of the Association of Directors of Social Services. He is Director of Adult Social Care in Nottinghamshire and also is the lead of the Sustainability and Transformation Partnership that's trying to integrate health and social care and beyond in that part of the country. So a great deal of expertise and insight, and he's also advising the government as an expert advisor on the production of the Green Paper. So I'm really looking forward to hearing what David has to say. Thank you very much. David.
Good morning, everybody. When I started as a social worker in Bulwell, in a deprived part of Nottinghamshire at the age of 23, with my open-toed sandals, long shaggy beard and Citroen 2CV, and some people have still got the photographs, the average life expectancy of somebody with Down syndrome was 23 years, and that was the age that I was then. Next year, with a bit of luck, I will achieve my 60th birthday, and the average life expectancy of somebody with Down syndrome today is 60 years. In Nottinghamshire, each and every year, there will be a 4.5% increase in the over 85s in the county. It's the biggest demographic explosion of longevity since the dinosaurs in history. And it's a fantastic tribute to the economic development of our country and advanced economies in the world, but it is also an important thing that we as a nation have to address. So it's a distinguishing feature of our time in terms of the demography and the technology and the resources that we have, that in most economies they're struggling to keep pace with the need and demand that's required. And Paul's just given you a tour de force of some of the issues that arise from that. It's not widely understood in this country that, in fact, we have a huge increase in longevity of younger adults with disabilities in the way that I've just described. And in the English social care system, younger adults constitute 28% of the people served, but 55% of the adult social care budget. And to the 4 years to 2015-16, there was a 5.6% increase in that budget as the costs or the pay for older adults reduced. And I want to now go on to talk about some of the solutions to this. And in that regard, I'm assuming that we are going to invest in a country appropriately in social care and health. And we've seen the response through NHS 70 of a 3.4% increase over the next few years in the health budget. We are yet to see the necessary increases in adult social care. And my one point about that is that the Institute of Fiscal Studies and Health Foundation report published earlier this year indicated that up until the current day, since 2009, there'd been a 10.3% increase in health expenditure. At the same time, and this is in England, a 9.9% reduction in funding for adult social care. Different statuses and different levels of investment across the UK, but clearly we need to make sure that the two sides of the key elements of health and care are funded appropriately. Technology can also help. We are amidst a revolution in the way that we gather and use information, and the technology to better understand need and the way in which we can help to meet it. The principles of sustainability and transformation partnerships, or integrated care systems, as some of us are now being called, is that we need to better manage and understand the needs of the population in the future. We've spent a lot of time actually managing the system and having measures that manage the system rather than managing the needs of the population in the individuals within it. So I think there are some three principles to this. First of all, to understand the needs of the population and how it will change. Identify those with greatest need and risk and proactively respond to their needs, reducing that risk. To principles of independence, reablement, rehabilitation, and utilising people's strengths. And Kay's powerful testimony this morning was just an example of how we need to remember the people in this, and they should be at the heart of it. And through that process, then identify people who can and want to take control. Person-centred coordinated care based around people's needs and those of their carers. So the best systems in the world integrate health, and it's become very fragmented in many economies, including in this country. Integrate health and care, but integrate health care and wider public services. And I'm thinking particularly of housing, but others in the community and voluntary sector. And for the Sustainability and Transformation Plan that was created by Nottingham and Nottinghamshire 2 years ago, we were one of the only systems that had housing and environment and technology-enabled care as some of our principal objectives. But they seem to me to be critical. So I wanted to spend a few minutes just talking about what difference this can make to people if you do adopt this approach of understanding people's needs, so that we are delivering prevention from obesity in childhood to helping people at the very end of their lives not have to spend the last 36 hours of their life in a hospital setting, in an acute admission ward, which generally has no evidence for its benefit and does people a lot of harm, in my view. So enhanced care in care homes. We have a system in Nottinghamshire, as in other parts of the country, where there's a good linkage between primary care and care homes. And the result of that, through that consistent proactive intervention and assessment, is that A&E attendances have gone down by 29% and admissions by 23%. And to give you a personal example, my own father had vascular dementia and many other long-term conditions and died in February of this year. And he spent the last year of his life in a Nottinghamshire care home. Many health colleagues defined the end of life as people who've probably had 3 or more admissions to hospital in the last year of life. My father had none. And it wasn't just because his son was standing at the door of the nursing home making sure that he didn't go into hospital, but because there was good proactive care between primary care and the nursing and caring staff. And that meant that my father could die cared for by the people who got to know and love him in the home, as well as holding the hand of his son and the rest of his relatives, which is how it should be. Multidisciplinary working in primary care. So we're looking here at a range of professionals, which I'll say a little bit more about in a bit. But through the evaluation we've done through Nottingham Trent University, with a control group, we've indicated that A, there are better outcomes arising from this work, 13% more people at home than in the other group, and admissions to hospital went down by 12%. Technology-enabled care. So just a few examples of that from Nottinghamshire. A man with learning disabilities in his early 50s, Peter, capable of some personal care, but needing several care visits a day and sleep-in provision. He had indicated through closing the door on staff on occasions that he perhaps wanted more privacy. He had a lifeline, but he was nervous of technology and speaking to strangers. So he was given a new telecare system, a pendant, carbon monoxide and smoke detectors, property exit sensors on the front and back door, and people worked intensively with Peter to help him use the equipment. Somebody alighted on something that he really liked and made the connection. He liked superheroes, and it helped when staff explained that it was like having the bat phone in Batman. He was trained to respond to the smoke alarms and had just checking at night because people were concerned that he might be more anxious and therefore needed to understand that. He was initially. His activity at night was greater, but that calmed and he became more confident. He's now happy to speak to the Lifeline staff. He's more confident in communication generally, and there's been a saving of £25,550 from his care package. A woman with dementia, able to do daily tasks, been problems over the cooker and lighting it, so there were risks from that occasion. Police have found her disorientated, several miles from home, and the GP and the family thought the only option was residential care. So the property was alarmed through the door through to the porch, and what was decided was that because it took her some time to get through the next door, that would give an indication back to the Lifeline people that she was seeking to leave. So an exit sensor was put in, and that immediately rang through to the Lifeline, and they talked to her between 7 p.m. and 7 a.m. if this happened, and persuaded her that she didn't need to go out. And again, checking on her activity indicated that actually this solved the problem. So we need to be able to tell those stories and indicate how these things help people, as well as the hard data. In relation to Call for Care is a crisis response put in place in mid-Nottinghamshire, and there are lots of services that can be provided that have generated particular benefits for the system, including reduced admissions, people staying at home for longer. Housing, health and care. We have a number of housing and health and care schemes in Nottinghamshire, but particularly the Assist scheme, which is helping people get home from hospital, where council workers provide proactive support very quickly to people. And we've had, the record is 40 minutes between somebody getting referred and a key safe fitted on their front door so that carers could get in and the person could be discharged later that day. These things sometimes take 4 days in other systems. Integrated personal commissioning. We are a pilot for integrated personal commissioning from the health side, and we have increased from 85 to 2,000 in the last 18 months. We're also announced as a fast-track area for health and care integrated personal commissioning, along with Lincolnshire and Gloucestershire, and we have 500 personal health and care budgets. And Helen said of her son Carl, who has a learning disability and is in transition from childhood to adulthood, the difference was immense. We went from being done to being done with. We work together so Carl's needs are met on a personal level rather than one size fits all. A tremendous testimony. So just a quick drill down into some of the multidisciplinary working with risk stratification, understanding those people at greatest risk, GPs, district nurses, specialised nursing staff, social care, therapies, voluntary sector representatives, all in the same team working in different parts of the service, but around primary care. And we've seen those reduction in hospital admissions, reduction in admissions to residential nursing care, and greater use of lower level services, and more service users and patients and citizens staying at home, which is where we want to care for them for as long as possible. And again, just a bit more about Call for Care. So this has led to this response within 2 hours for people at risk of hospital admission or residential nursing care, avoided attendances by ambulances of 1,520, avoided admissions 613, and reduced lengths of stay in 216 cases. A benefit of over 1.5 million to the system. So, in summary then, the future of health and care in the UK and in every other advanced system in the world is most definitely using a population health management approach, understanding the data and making sure that we're addressing the needs of the population from cradle to grave with the right interventions, reducing unnecessary variation and using the best innovation that we can. And therefore, those best health and care systems use and share data, information, outcomes and risk to understand and serve the population, both today and tomorrow, because it is changing rapidly. And in Nottinghamshire, we've developed a data warehouse with over 500 million records. We haven't got 500 million people in Nottinghamshire, but we have got 500 million records, which just shows how many there are, whereby we can use that information to understand the needs of the population and make sure that we're addressing them proactively. So some of the schemes that I've talked about use that information, as well as joint records in a number of cases, which we're rolling out because 100% of GPs have signed up to data sharing protocols, something that I never thought I would see in my career, but quite remarkable in terms of its power for the future. So we need to integrate to provide that person-centred coordinated care that Alison referred to. Innovate whilst dealing with today's challenges, utilising those new opportunities which technology can demonstrate when it is delivered safely with quality and cost effectiveness. So it's important that that is transparent, that the confidence of the stakeholders and of commissioners and of the public is enhanced as to what this can do. Because we're all, let's face it, limited by our own imagination. So we need to instill that confidence and that understanding. And momentum is important. Success breeds success. So when you're talking about change and transformation, this doesn't mean much to the public or indeed many workers in the field. But what it does require is those stories and that evidence, because we need to spread that knowledge and understanding. This is a movement as much as a technical exercise. And finally, we need to invest in the culture, capacity, and the change. This is about people collaborating and working together across the system and across the sector. And we need to communicate with our head and our heart. So we need the evidence, we need the systematic evaluation, but we also need to understand what difference this makes for real people. Thank you very much indeed.